Good morning, everyone. I am Dr. Madhurima. Today I am going to present a paper on surgical outcome in patients with complicated cataract secondary to uveitis. Cataract in uveitis may develop as a result of intraocular inflammation or from chronic corticosteroid use. The incidence of cataract in uveitis ranges from 57% in pars planitis to 78% in Fuchs. Cataract surgery in uveitic eye is usually challenging task than a non-uveitic eye, usually due to extensive posterior synechiae, small myotic pupil, fibrotic anterior capsule, and big zonules. Until 2 decades ago, the outcome of surgery in these eyes was guarded because of confounding postoperative complications. However, with modern day cataract surgical techniques, improved understanding of disease process, optimization of immunosuppression, and biocompatible IOLs, the design of IOL design and material, the outcome has been maximized. The aim and objective of my studies is to study the morphological types and distribution of various complicated cataract in uveitis to evaluate the visual outcome undergoing cataract surgery for complicated cataract and to assess the intraoperative and postoperative complications. It is a retrospective observational study conducted over a period of 1 year in Arvind Eye Hospital, Tirupati. The inclusion criteria is the patient's age more than 12 years, patients with complicated cataract following uveitis, where uveitis is either inactive or under control with AC cells less than 1+, and with medication for at least 3 months before surgery. Exclusion criteria is acute active uveitis, case of recurrent uveitis with acute exacerbation, and patients with PL negative. Selected patients underwent a detailed examination, BCVA, slit lamp examination, fundus examination, and IOP. Cases with total cataract underwent B-scan ultrasonography. Patients with visually significant cataract and quiet eyes for a period of at least 3 months were taken into the study. Additional steps were done in case of small non-dilating pupil, extensive synechiae, and in the presence of pupillary membrane. Follow-up was done on day 1, 1 month, and 3 months. The mean age was observed to be 47 plus or minus 16.5. The majority of the patients belonged to the age group of 61 to 70 years, followed by 21 to 30 years. The pre of visual acuity, most of the patients belonged to the visual acuity of 6/60 to 1/60. Females were more than males. Females were 56% and males were 44%. Majority of the patients, the 44% of the patients were for total cataract. The posterior subcapsular cataract with nuclear cirrhosis was observed in 35%, and posterior subcapsular cataract with cortical cataract was observed in 21%. Majority of the patients underwent small incision cataract surgery followed by phacoemulsification. Majority of the patients belong to the anterior uveitis group, the 53.50%, followed by intermediate uveitis, pan uveitis, and then the posterior uveitis. The type of IOLs implanted, 30% of the patients were implanted with acrylic lens, 5% with aspheric, 9% with eye vision IOL, 49% with PMMA. One patient was implanted SF IOL, and 2 patients were left aphakic. Intraoperative procedures additional were done. CTR was used in 1 patient, iridectomy in 2 patients, pupilloplasty was done in 4 patients, iris hooks were used in 2 patients, capsule hooks in 1 patient, sphincterotomy in 4 patients, synechialysis in 8 patients, primary posterior capsulotomy was done in 1 patient, and anterior vitrectomy in 3 patients. The postoperative visual acuity was observed on day 0, day 30, and 3 months. The best corrected visual acuity improved to 6/12 or better in 72% of the patients on day 30. It improved in 23.4% of patients from 618 to 636. Only in 2 patients, the visual acuity improvement was not seen. This was due to the pre-existing posterior segment pathology. So 43 eyes of 43 patients having complicated cataract following uveitis with visually significant cataract were taken up for the study. The peak incidence of age was 61 to 70 years. The most common morphological type of cataract observed was posterior subcapsular type, followed by total cataract. Majority of the patients went SICA surgery and then phacoemulsification. After the cataract surgery, the majority of the patients in our study, the post-operative at 1 month, the corrected distance visual acuity improved in 72% of the eyes. Okay. The most common complication encountered was recurrence of uveitis in our study, followed by posterior capsular opacification and cystoid macular edema. Intraop complications observed was zonular dialysis in 5 patients and posterior capsular rent in 3 patients. Conclusion is there was a statistically significant improvement in visual outcome after cataract surgery in complicated cataract secondary to uveitis. The use of pupil dilatic techniques like iris hook sphincterotomy was helpful in making an adequate size capsule exist and thereby reducing the postoperative complication. The most important predictor for successful cataract surgery in our study was meticulous control of preoperative inflammation followed by regular follow-up after cataract surgery. Thank you.
Was there any difference in the results between PMMA lens and acrylic lens implanted by?
Sir, actually here in this study we have not done that, but actually in the acrylic lens it was relatively better than the PMMA lens. The complication rate was relatively less in acrylic because phacoemulsification was done. So cystoid macular edema was observed less, but that was not done in these studies. So sorry sir, I'm not.
Dr. Vishnupriya? Dr. Vishnupriya?
So can you wait for 30 days? See, the next, following first post-operative day, again you said that, you have seen the case after 30 days. So can you wait for 30 days in between without seeing the patient in a case of a complicated cataract?
It's actually to follow up. It's better to follow up even on day 1, day 15 and then day 30. So after 2 weeks also we have to see, because there may be increase in your inflammation, sir. Yes, sir. We have done on 30-day follow-up because in our institute most of the patients are from very far away. So the follow-up is really difficult in our institute. So. Yes, sir.
Please switch on the mic. Switch on the mic.
Go close to the mic.
In certain cases, you are not supposed to put the IOL.
Yes,
You have
ma'am.
not mentioned that, and you have mentioned that the anterior chamber has to be quiet. So how much quiet it has to be?
Less than AC cells less than +1. Ma'am.
Yeah, and post-operatively, you have mentioned a lot of recurrence in uveitis. What was the reason for that?
Sorry, ma'am. Reasons for?
Post-operatively in complications, you have mentioned recurrence of uveitis. What was the reason for that?
There was intense inflammation, ma'am. After at day 30 it was observed, inflammation was observed, ma'am. Recurrence of uveitis was observed. So in our study, it was because of the patient in compliance with the one who's not compliant with the treatment, ma'am. The usage of steroid drops were not correct. We have tapered it over 3 months, but few patients have not used it properly. So most of it was observed that because of the non-compliance to treatment, there was recurrence of uveitis.